If you're in your 40s or 50s, eating the same way you always have, maybe even exercising more than ever, and the weight just won't budge, maybe it's even going up, I want you to hear something. This is not a willpower issue, this is a hormone issue. And today, I'm going to explain exactly what is happening in your body and what you can do about it. My name is Dr. Alessia Ronelt. I'm a double board certified endocrinologist. That means I'm board certified in both endocrinology and internal medicine. I specialize in hormones, metabolism, and women's metabolic health. I see patients every week who come in frustrated, come in confused, frankly exhausted from trying to figure out why their body has changed so much in midlife. And the answer almost always comes back to the same set of hormonal shifts. In this video, I'm going to be walking you through 4 key reasons perimenopause causes weight gain. Specifically, what's happening hormonally and metabolically, and what the evidence actually supports for addressing it. I'll also talk a little bit about GLP-1 medications at the end, because that is a question I get asked constantly in my practice. Stay until the end, because I'm also going to tell you about something I just built that I think is going to be genuinely helpful for you as well. Let's start with the most important mechanism, the one that explains more about perimenopausal weight gain than almost anything else. And that is the relationship between estrogen and insulin sensitivity. Estrogen receptors are present in your fat cells, in your liver, in your pancreas, and in your muscle tissue. When estrogen is working normally, it helps your cells respond efficiently to insulin. Insulin's job is to move glucose from the bloodstream into your cells to be used for energy. But when your cells respond well to insulin, blood sugar stays stable, energy is consistent, your body doesn't store excess fat. But as estrogen declines in perimenopause, that insulin sensitivity also decreases. Your cells don't respond as efficiently. Insulin levels rise trying to compensate for this. And chronically elevated insulin tells your body to store fat, particularly right in the belly. This is why so many women notice this shift where they start to carry their weight in their belly once they hit their 40s. It's not random, it is driven by this hormone cascade. What this means practically: number 1, carbohydrates that your body handled just fine when you were 35 will now cause much more significant blood sugar spikes at 45. This is why a diet that worked for you before may not be working for you now. Not because you're doing anything wrong, but because your metabolic environment has genuinely changed. The solution isn't to cut out carbs completely, it's to eat strategically. Number 1, protein at every meal. Number 2, fiber with every meal, because that slows glucose absorption. And a 10 to 15 minute walk after eating. Because research shows that this short little walk can reduce your blood sugar spike by up to 30%. Now, I'm going to come back to all of these details in just a moment. The second reason is closely related, and it's something I want to spend a moment on because it causes so much distress for my patients, and that is fat redistribution. In the body, there are 2 main types of fat. There's subcutaneous fat, that's the fat that's just kind of under your skin, the kind you can pinch, and visceral fat, which is stored deep in the abdomen surrounding your organs. Visceral fat is the bad fat. It's the metabolically dangerous kind. It drives inflammation, it worsens insulin resistance, it even increases cardiovascular risk. But here's what happens in perimenopause. As your estrogen declines, fat that was previously stored as subcutaneous in your hips and in your thighs starts migrating to the visceral compartment, your abdomen. This is why women in their 40s and 50s often say that their body shape changed completely, even without a significant weight gain. That is real. This is not just in your head. And this is driven by estrogen. Here's the good news though. Visceral fat responds really well to targeted interventions. Blood sugar management can help, strategic protein intake, resistance training, and optimizing sleep. All of these I'm going to cover, specifically targeting the visceral fat. The goal here isn't just weight loss, it's metabolic health, and those are actually different things. The third reason is muscle mass. I can't overstate how important this is. Muscle tissue is your metabolic currency. It's the primary site of glucose disposal in your body. More muscle means better blood sugar control and a higher resting metabolic rate, meaning you're burning more calories at rest, and better insulin sensitivity. In perimenopause, you lose muscle mass faster than at any other time in your life. This is a process called sarcopenia, unless you're actively working against it. Declining estrogen directly accelerates this muscle protein breakdown. And if your protein intake is low or you're not doing resistance training, you're going to lose a significant amount of muscle mass over just a few years. This is one of the main reasons metabolic rate slows in midlife. It's not aging itself, but the muscle loss that comes with the hormonal shifts. The two evidence-backed interventions, protein and resistance training. You want to target 1.2 to 1.6 grams per kilogram of body weight of protein a day. So for a 150-pound woman, that's roughly 80 to 110 grams per day, significantly more than most women are eating. And resistance training at minimum 2 to 3 times a week, not cardio, resistance training. This is the most important exercise recommendation I can give to perimenopausal women. Keeping up with the cardiovascular exercise is great for your heart and your mood and everything else, but in order to hold on to that muscle, you need to incorporate the resistance training. The fourth driver of perimenopausal weight gain is cortisol. And this is one that most people aren't talking about enough, or maybe talking about in the wrong way. Cortisol is your primary stress hormone. In a healthy cortisol rhythm, levels are highest in the morning and taper down throughout the day. But in perimenopause, the rhythm can be disrupted. Declining estrogen and progesterone both affect your HPA axis, which is basically your body's command center for hormones and a system that helps to regulate cortisol. This results in many perimenopausal women having cortisol that stays too high too long. They also might get more dramatic spikes or more of a dramatic spike in response to an everyday stressor. Sometimes they can get surges in the middle of the night, like at 3 o'clock in the morning when they're awake and wired for no good reason. And chronically elevated cortisol can raise blood sugar independent of what you eat. It can promote visceral fat storage, specifically in the abdomen. It can even interfere with thyroid function. And it degrades muscle. So it's working directly against every goal you have for your metabolism. The antidote is not a supplement to suppress cortisol production. It's actually changes in your lifestyle. Morning sunlight within 30 minutes of waking, consistent sleep and wake times, and trying to avoid really intense exercise late in the evening when your body is trying to wind down. Sometimes even eating your first meal within an hour of waking can also help to regulate this. So these aren't just wellness suggestions, they're actually evidence-backed cortisol management strategies. Now, I want to spend a couple minutes on GLP-1 medications because I get asked about this constantly. And I think there's a lot of confusion about whether they're appropriate for perimenopausal women specifically. Recent data looking at over 13,000 US adults shows that GLP-1 use is actually highest among perimenopausal women. Now, this makes complete biological sense because this hormonal shift in perimenopause is creating exactly the metabolic environment that insulin resistance, the appetite dysregulation, the visceral fat accumulation that these GLP-1 medications target. Research has shown that tirzepatide or Zepbound Mounjaro produces approximately 20% weight reduction across all menopausal stages. And there's emerging data to suggest that women on semaglutide or Ozempic and hormone replacement therapy lose more weight than those on semaglutide alone. That said, GLP-1 medications are powerful tools, but they're not magic. The outcome depends entirely on how you use them. The biggest risks in perimenopausal women are muscle loss and bone density reduction, both of which are already accelerated by hormonal decline. If you're on a GLP-1 and you're not prioritizing protein or you're not prioritizing that resistance training, you may actually be losing muscle faster than fat. Now, I have a lot more to say about this, including how to use GLP-1 medications wisely in perimenopause. That's all in my new course, which I'll tell you about in a minute. So to sum up, perimenopausal weight gain is driven by 4 interconnected hormonal mechanisms: declining estrogen, reduced insulin sensitivity, fat redistribution from subcutaneous over to visceral, and muscle loss, which is accelerating that metabolic slowdown. And cortisol dysregulation is compounding all of it. These are not separate problems. They are one interconnected hormonal picture, and they require a strategy that addresses all 4 simultaneously. The evidence-based strategies are protein at 1.2 to 1.6 grams per kilogram of body weight per day, resistance training 2 to 3 times per week, blood sugar management through meal composition and post-meal walking, circadian rhythm alignment for cortisol. And for some women, a conversation with your doctor about HRT or GLP-1 medications as a comprehensive approach. Now, I just launched a waitlist for a course that I've been building called the Hormone Reset. It's a physician-led digital course specifically for women in perimenopause and menopause that goes deep into everything I talked about today and more. We cover GLP-1s in detail, HRT and compounded hormones, how to read your own labs, the exact nutrition and exercise protocols for your hormone phase, and how to build a personalized protocol that actually works for where you are right now. The link to join the waitlist is in the description below. It's free to join the waitlist, and waitlist members will get early access when enrollment opens. I would genuinely love to see you there. If you found this helpful, please hit subscribe. I post evidence-based hormone and metabolic health content every week. And leave me a comment below. Like, what is the symptom in perimenopause that's been most frustrating for you? I read every comment, and it helps me know what to create next. See you next time.